Hey, this is Angry Bill for Pre-Hospital Wisdom. I want to talk to you about pacers, specifically transcutaneous pacemaking with the Physio-LIFEPAK 15. That's the one I'm most familiar with. Most other transcutaneous pacemakers are vaguely similar associated with it. This is part two of a two-part series. The first part, I will leave a card up here somewhere, I think. That was last week where we described a symptomatic bradycardia patient having a STEMI and a third-degree AV block and discussed atropine over pacemaking and all kinds of stuff. So check that out if you haven't already. Step one, when we decide to go ahead and initiate pacemaking, is to have the Combipads on the patient. I'm kind of fine if you are the kind of person that wants to follow the drawing on the Combipads. There was another video a couple of months ago where I talked about the efficacy of anterior-posterior placement in compared to anterior lateral. This works for pacemaking as well. So for me, if I remotely could with the patient, I'd go with an anterior posterior placement. But in any case, once you got your pads on and everything. The other important part for pacing on a LIFEPAK 15 is to have all four of the frontal lead electrodes, right arm, right leg, left leg, attached. Without those attached, the pacemaker is a fixed rate pacemaker. Once those four electrodes are attached, it becomes a demand pacemaker, and so the pacemaker only works as it's needed. With all six of those stickers attached and something attached to all six stickers, we can begin. This is a LIFEPAK 15 that I have hooked up to a rhythm generator here, showing us a third-degree AV block with a rate of about 40, maybe the high 30s. I know that because the P to Ps aren't matching up with the R to Rs and both are regular, but also because I hit the third-degree block button on the rhythm generator. On the LIFEPAK 15, over on the right side, there's an area kind of delineated over here for the pacemaker settings. So I'm going to turn the pacemaker on by pressing the pacemaker button. What should happen at this point is all of the patient's native beats are marked by a solid triangle on the QRS. That's showing what the monitor assesses as a native beat that would inhibit the pacemaker's actions, that would inhibit the LIFEPAK's actions. One of the things to keep in mind is to make sure that it's seeing what you think are QRSs as well. If your QRSs are especially small or you have a lot of artifact in the lead that's showing on the monitor, the LIFEPAK is going to be confused. And so one of the things to do is to change the lead view because the monitor reads this top lead on the screen. So find a lead with good QRSs, and so that way the solid triangles will mark your leads. From there, look to the rate here on the screen. The rate is preset on every LIFEPAK 15 I've ever worked with at 80. 80 seems to be a reasonable rate for adults, especially adults that are holding still and whatnot. If you feel the need to dial it up, like if you were pacing a child or something like that, I think that's fine and reasonable thing to do, but I also think that 80 is a fine thing. Next is milliamps. So I hit the speed wheel to lock in the rate of 80, and then next is the milliamps. And I can dial that up in two ways. I can dial up the current on the LIFEPAK itself, or I can click the speed wheel higher and higher. By clicking the speed wheel, I move it up by 5 milliamps. By using the button on the LIFEPAK, I move it up by 10 milliamps. So one way or the other, we keep moving this up until I get capture. At this point, you can see on the screen I have capture. This is what capture looks like, a pacer spike followed by a QRS with a T wave and everything else. But I want to show you what false capture looks like. This is an example of what false capture looks like on a LIFEPAK 15. Each one of these spikes is actually a pacemaker spike. It's a pacemaker spike with a narrow, with the narrow impulse, followed by this large ramp-looking thing that can simulate a QRS. That is what a pacemaker spike looks like to a LIFEPAK 15. Essentially what's happening is there's a pacemaker spike that fires, and then the monitor averts its eyes and blinks while that electricity runs through and then resettles itself, causing that big ramp. This is not capture, and unfortunately this can simulate QRSs to people that don't know the difference. In addition, muscle twitches can simulate a pulse in some cases, and the pain of being shocked 80 times a minute can wake up patients and cause what looks to be a symptomatic improvement in mentation. So be careful. This is not what electrical capture should look like. This is what ineffective pacemaking looks like pre-capture on a LIFEPAK 15. Be careful of that. Once you do have capture, it should look something more like this. So you notice that there's no native beats mixed in, especially soon right after the pacemakers, soon after the pacemaker spikes. In addition, there's T waves associated with it. This is what a paced rhythm looks like. So this has electrical capture. Step one when you get capture is to look around for the person closest to you to high five them. Check your patient. Check to make sure that there's mechanical capture going along with that electrical capture. Check a blood pressure, check their mentation, check if they need more sedation or analgesia. Stabilize yourself. One of the other things I do is a little bit controversial maybe. I've heard some people, once they get electrical capture, will dial it back by 5 milliamps to lessen the amount of electricity being put into the patient's heart. I've seen some paramedics say that they would just leave it there, and I've seen some paramedics say that they would dial it up a little bit. And to me, I go one click higher than I had capture at. I want it to be vaguely above capture. Now, I don't need to be blasting 300 milliamps into a patient, but bumping it up by 5 milliamps just makes it more difficult for me to lose capture. Those repeated impulses can raise resistance to the electricity and cause loss of capture. In addition, a little bit of patient movement might change some of the vector of the electricity or some of the orientation. And so if I was just barely above the pacemaking capture threshold, that little bit of movement might lower it down just that little bit and cause me to lose capture, especially if I'm not paying attention. So I want to show you some things on a LIFEPAK 15 that I think are vaguely helpful to see or to know. On this LIFEPAK, once I have capture, if I change the rhythm to a sinus tach and make it go faster than the pacemaker is set, pacemaker set at 80, if I make it go faster, the pacemaker shuts off automatically. That's what is meant by a demand pacemaker. It only goes when it needs to go. When there's demand for it is when the pacemaker fires. So that's kind of a cool thing. For that to happen though, all 4 frontal leads, all 4 frontal electrodes need to be attached. And there's no audible alarm or anything like that when one of them comes detached, or when someone cutting pants off cuts a wire, or any of those things. The only thing that changes when I pop off one of the electrodes from the rhythm generator is you can see at the very bottom of the LIFEPAK screen, it says non-demand. And as I rehook it, it says demand again. So be careful of that. It's a potential pitfall. One of the other things to keep in mind or to see done is the pause button. Occasionally I want to see what's going on behind this rhythm. I have a paced rhythm, I have good capture. I want to make sure that there's not something going on behind there that I need to see. So I can hold down the pause button and pause the pacemaker, not change any of the settings, not do anything like that, and see what the underlying rhythm behind it is. In this case, there's no paper in the monitor, so it doesn't drive us insane when it's used for teaching. But normally when you hold down pause, the printer starts printing, and so that way you can even tear it off and look at it more slowly at your leisure or whatever. So that's how a pacemaker works. Some of the important things to keep in mind is just the process of how you work through it. Make sure to not be tricked by the LIFEPAK's pacer spikes, which are what we consider a spike followed by a ramp. The ramp is not a QRS, the ramp is part of the pacemaker spike. A pacemaker spike has a wide QRS followed by a T wave, right? There's some other stuff that maybe a future video we could cover, stuff like failure to pace, failure to capture, failure to sense, some other failures like that. But for the most part, certainly implanted pacemakers don't fail at the rate that they used to 20 or 30 years ago. They don't usually have problems. They're not usually an issue whatsoever. Let me know if you want me to discuss the failure to pace, failure to sense, failure to capture. Those might work into some shorts, go a little bit easier. Let me know down in the comments what you want to see. My name's Angry Bill. This is Pre-Hospital Wisdom. You know all the YouTube stuff, all the like, subscribe, share. Make sure to get the word out. I appreciate you. Until next time, stay safe.